Hi, my name is Courtney. I am the director of Tapestries, the memory support community here at United Methodist Communities at Pittman. I am a social worker by background, and I have a lot of experience in senior care, brain injury, mental health, and education. Basically, all things related to the brain, which is what makes me so interested and passionate in brain health and dementia awareness and passing that information on. So that's a little bit about me. Also, I apologize that this video cannot be in our usual live format. I am on maternity leave, so I'm pre-recording so that you can continue to get the support and assistance that you need even while I'm out. Because of that, I may be short of breath here and there throughout. I've got two babies sitting in my lungs, so bear with me. But today we're going to be talking about medications and treatments for dementia. This is a topic I get a lot of questions about from our families. And so this is just a quick overview of the most commonly asked questions that I get. So as we get started, first and foremost, this information is very general. I did do a lot of research to be able to present this information as clearly and concisely as possible, but it is not by any means a complete representation of treatment options or how well they work or the safety statistics that go into them. Please do not take this as medical advice. Please feel free to use this as a jumping off point to do your own research into what's right for you and your family. This is just meant to be, like I said, informative to answer the questions that families most frequently ask me. So this is going based off of what I'm hearing from you on a day-to-day basis. As always, medical decision-making should be done between you, your loved ones, your loved one with dementia, whenever possible, and their providers, their doctors. So all of that said, I also do want to point out that there is no cure for dementia at this time. So everything that we're going to talk about is intended to reduce symptoms, prolong quality of life, things of that nature, but there is nothing that's going to stop the progression or return function to our loved one that's already experiencing dementia. I do have some additional resources on this. So there's the Alzheimer's organization does a really great job of summarizing the general information, the most important information you need about each medication we're going to talk about in a way that's really accessible and user-friendly. There are other resources that you can use. By all means, feel free to use your own. But there are two additional ones that I've got here, drugs.com, which can be great just for the bare bones medication facts, what they do, how they work, what their side effects are. And then another one here, which is a little bit denser, but still pretty accessible, with some careful reading about how medications and dementia work specifically. So feel free to check those out. Feel free to look up your own. All right, so that said, let's dive in. Get ready, because this is kind of a dense topic. Lot of information. Okay. So the first type of medication that we're going to talk about is medication to address symptoms. So these are medications that are typically prescribed for people in early dementia, early to moderate dementia, specifically for dementia treatment. There are three main types, and all three work by changing the way the chemicals in our brain works. So just like a quick and dirty description of how our brain works is that we have all of these nerve cells, and they look almost like if you splayed your hand out, like they've got a lot of tendrils at this end. There's the nucleus, which is the brain of the cell. And then they have a long axon and a few more little tendrils down here at the end. They get very, very close to one another. And the gaps in between those little tendrils fill up with chemicals we call neurotransmitters, and the nerves react to those neurotransmitters, and there's tons of them, and each one does a different job, and that's how our brain interprets things. So all of these medications that we're going to talk about in this category are specifically focused on how those chemicals, the neurotransmitters, work, either by helping the brain keep them longer or by helping the brain make the correct amount of them. So hopefully that wasn't too confusing. So the first kind is a cholinesterase inhibitor. It works by preventing the breakdown of acetylcholine, which is a chemical that helps with memory and learning. So by preventing it, so the cholinesterase is the chemical that counters that acetylcholine and causes it to go away so it doesn't hang out for too long. So by preventing that cholinesterase from breaking it down, it lets the memory and learning chemicals stay there longer with the intent of improving memory, thinking, language, and judgment. Okay, so a lot of technical words, but that's what it's doing. It's trying to help with memory, thinking, language, and judgment. You may have heard of these as Aricept, Exelon, or Razidine. Those are the brand names. I've got, you can see on the slide here, I've also got their, technical drug names. They can cause some vomiting, appetite loss, frequent bowel movements, things like that. Some not so pleasant symptoms for some people. So it's really, as with all medication, it's about risk versus benefit. Another type is glutamate regulators, Again, glutamate, just another chemical in the brain that helps it communicate. And the way that glutamate does that is that it improves the way the brain processes information. So this one is regulating the amount of that to make sure the brain is able to process information as quickly as possible or as efficiently as possible. Excuse me. And it's intended to help with memory, attention, reason, language, and simple task performance. So when I say simple tasks, that changes over the span of dementia. So a simple task in the beginning might be, getting dressed, brushing your teeth, fixing breakfast, not necessarily cooking, but like a bowl of cereal, some toast, that sort of thing. In the later stages of dementia, those may very well become complex tasks. And so the definition of a simple task changes over time. So kind of keep that in mind. The most common one of these types is known as Namenda. Also very commonly prescribed for dementia. It has some of its own unpleasant side effects, most commonly headache, constipation, confusion, and dizziness. And then the third type is a combination of those two drugs. So you get both sets of benefits. You also get both sets of side effects. And so that one is Namzaric. I'm less familiar with this one. I haven't had too many residents prescribed this one. But again, it works in both ways. So all three of these types of medications are primarily effective in the early to middle stages. Though some can be prescribed throughout the progression of dementia, you will see that how effective they are decreases as our loved one gets more progressed in their dementia, just because there's only so much that these medications can do. And it's important to note that for all of these medications, they reduce the symptoms. So that's the part we can see of dementia, but they do not slow the progression, which is the part we do not see. Okay, so they are not stopping decline in the brain. They are not stopping our nerve cells from communicating or from losing communication. They are not stopping the development of the plaques and tangles that we currently know to be responsible for dementia. They're not changing the timeline of what's happening at all from a brain perspective. What they are doing is making it so our loved ones' day-to-day life is a little bit easier for as long as possible. Okay, so I think the simplest way for me to describe this is like, if you broke a bone, this is like getting pain medication, but not getting the bone set. Okay, bone's still broken, gonna stay broken, but it's not gonna hurt so bad. So there is value to it. But I think that this is a thing that doctors sometimes poorly explain, and that can be distressing for some families, specifically in the later stages, where it starts to look like it doesn't work as well. Because when it does get to a point where it's less effective, there can be a sudden change in how we perceive the symptoms, because the brain has been changing gradually all along, but suddenly we're seeing it as like a much more drastic change. So that's something we need to be mentally prepared for in the event that our loved one experiences that. Now, just kind of anecdotally, my own experience, I've also seen that these medications can sometimes make residents more anxious. You know, the brain is kind of being prodded into doing more than it is capable of on its own. And that can have some effect of like symptoms that mimic anxiety. So we might see more restlessness, we might see more fidgeting, we might see a little bit more irritability for some people. That's not necessarily what's indicated in the side effects here. That's just my personal experience of what I've witnessed. And so take that with a big old grain of salt, because most of our residents take multiple medications, and that could certainly be chalked up to any of those others, or to other factors in their lives and who they are as people. So, you know, so it's just a little bit of neither here nor there, but something to consider. Okay, so then the next kind of medication, these are very new in terms of medical treatment. But these are medications to address the biological factors that cause dementia. So when I say the biological factors that cause dementia, again, take that with a great big grain of salt, because we don't really know what causes dementia. We don't. We suspect, and there are a lot of studies to suggest, and the current best practices are that we believe many forms of dementia are caused by what we call plaques and tangles in the brain. So plaques are groups of beta amyloid kind of blobs that take up brain space and limit communication and do a lot of other things. And we think that's part of the process. We've got a lot of studies that suggest that that's part of the process, but it is not by any means a 100%, like, we know this is certain, it's the only thing that's at play here kind of a thing. In the, you know, in the scope of all there is to know about the brain, that's like having about 4 pieces of a 10,000 piece puzzle. And so if there's that much unknown about the brain, that means there's a lot of unknown about specific things that affect the brain, like dementia as well. And so even with the wealth of information we have, it's a drop in the bucket compared to what we don't know. So again, this is based on what we currently know to be true, based on the research that we have, and it's continually growing and changing. But so we believe that at least a part of the process of dementia is these plaques, and these medications are dedicated to removing those plaques. which we hope can, reduces the progression of dementia and can sometimes halt it. So there are two of these medications. I'm probably going to butcher the pronunciation of these. They are aducanumab and lecanemab, and their brand names are Aduhelm and Leqembi. And these are both administered as intravenous infusions. So that means your loved one would go to an infusion center or a hospital or a surgical center and receive an IV bag for 45 minutes to an hour every 2 to 3 weeks for whatever the duration of treatment their doctor recommends is. So it's important to know that these have only been tested for people in very early stages of Alzheimer's and mild cognitive impairment. So if your loved one is believed to have another type of dementia, vascular dementia, Lewy body dementia, Parkinson's related dementia, any of those, that's not to say this won't work for them, but it is to say that it hasn't been tested specifically for them. It's primarily focused on Alzheimer's and mild cognitive impairment, because Alzheimer's is the #1 type of dementia, the most common type of dementia of which we, see. So that's what their focus was. And it's only intended for use in the very early stages because we want to prevent the formation of plaques as early as possible to preserve as much of the brain as possible. So none of these studies have been done on people in moderate and later stages. So this is something that if you wanted to pursue it, you would want to pursue it pretty much as soon as your loved one is diagnosed with dementia. Not a lot of indication whether it would work in later stages. Okay. So all of that said, these medications have been proven to reduce the amount of plaque in the brain. That's the only thing that's been tested. So we know that they have been proven to reduce plaques, which is great. There is some anecdotal evidence by study participants, so the people that have participated in these research studies and their families. Some will say that they saw a reduction in the progression of symptoms. So let's say they were diagnosed 6 months ago. It was a really hard 6 months. And now they're feeling better and it feels like things have slowed down for them. That's basically what they're saying. Some are also saying that they are seeing improvement in retention of functional abilities. So one of the first things that we see to go, or some of the first things we see to go in those early stages, are the ability to do complicated tasks. Driving, cooking, paying bills, things like that, grocery shopping, stuff that requires a lot of mental energy. Some of those study participants say that they feel better able to continue doing those things. It's important to know that that handful of people, and I couldn't tell you how many people in the study there were that reported that, but that handful of people are saying that's been their experience, but that specific goal of the medication has not been tested. So the science doesn't back that up. Some people do. So take that for what you will. There is no evidence that these medications can reverse cognitive decline or functional decline that has already occurred. So the sooner the better as far as getting these medications is concerned, because if you wait, you're not getting back what's already lost. We hope that these medications prevent further loss. There's some evidence that they prevent further loss, but we're not getting back what's already gone. They're not bringing back brain cells that have already died. Okay, so we definitely want to make sure that we're pursuing these medications with a healthy dose of reality as to what they're capable of and what they're known to do. So as far as side effects for these medications, we can have infusion-related reactions. So, allergic reactions, skin irritation at the infusion site, things like that. Kind of like if you go in for surgery, it doesn't matter if you're having, like brain surgery or liver surgery or, knee surgery or whatever. Surgery inherently includes a risk of infection. Infusion's kind of the same way. It inherently includes a risk of infection, a risk of allergic reaction, things like that. So that's always a possibility. Headaches, dizziness, falls, and a condition called ARIA. So ARIA sounds scary. It is a condition where there is temporary swelling of the brain that can contribute to bleeding in the brain. It can contribute to headache, nausea, dizziness, confusion, vision changes. It can be potentially dangerous or even deadly. That is rare. And it is usually temporary, and the consequences are usually reversible. So it's a scary sounding side effect, but it's a risk you want to consider with your medical professionals and determine whether or not that's right. Okay. One of the other tricky things about these medications is that they will only be administered if you can prove that there are plaques in your loved one's brain. And so the process of proving that requires some pretty invasive and unpleasant testing. So you can get a PET scan to prove whether or not there are plaques, or you can get a lumbar puncture, which is a very large needle being inserted in the base of your spine, to prove whether or not there are plaques. Typically, insurance, particularly Medicare and Medicaid, are not going to cover those procedures, so they are expensive. You would likely have to pay for them out of pocket, and you're not eligible for these medications unless you've done at least one of those tests and had proof that plaques exist, because they don't want to take the risk of causing these unpleasant side effects if it's not going to give you the benefit. And if there's no plaques, there's no reason to remove plaques. So just something to be aware of. It's also important to know that Medicare has extremely limited coverage for these medications. You have to qualify for them. They're an extremely high cost. I think the best estimates that I saw in my research were about $26,000 a year for these treatments. That's a lot of money. So if Medicare doesn't cover it, that's definitely a prohibitive factor that might reduce your ability to even entertain this idea. Technically, Medicaid will cover it, but not if your loved one is dual eligible. So if your loved one has Medicare and Medicaid, they go by the Medicare rules. If your loved one only has Medicaid, Medicaid will cover any medication that is certified by the Food and Drug Administration, the FDA. So Medicaid will cover those costs. However, because the medications are so new and so costly, the availability of them is limited. So even with Medicaid coverage that'll cover the cost, you may find that there are travel-related expenses, that it's very hard to find a provider that will give it, those sorts of things that might still make it hard to get to. So that's kind of a touchy subject. We hope that over time, these medications will become more available. And the other part of this is that because these medications are so new, there is no long-term data on their efficacy or their safety. So we know what the people who've been tested in the last few years have experienced, but we have no way of knowing what their functioning or their health look like 10 years from now, 20 years from now. And so that's something we want to think about if we're being diagnosed with dementia, with early dementia in maybe our 70s or 80s. People are living to 80s, 90s, even 100s these days. we need to know what that long-term data looks like, and there just isn't enough of it yet. So that's also something that you want to be aware of as you go into that conversation with your doctor. Oh, I think I skipped one. Nope. Okay. All right. So then alternative treatments and supplements. This is a big one. I hear about this all the time. Excuse me. These are your over-the-counter vitamins, miracle cures as seen on TVs, that sort of thing. So fish oil, omega-3 fatty acids, usually those terms are used interchangeably. CoQ10, coenzyme Q10, if you've ever heard of that, coral calcium, ginkgo biloba, St. John's wort, there's a bunch of different ones. There's probably dozens. But these are basically all medications, well, not medications, supplements, that we can typically obtain over the counter, which is nice. They're relatively inexpensive. They're very easily accessible to a wide variety of people because they're so available. For the most part, they are derived from nature. So they come from plants and animals. Ginkgo biloba is a plant. Coral calcium is calcium derived from coral, that sort of thing. Fish oil, self-explanatory. That is not to say that they are all natural products. There is a certain amount of refining and mixing of ingredients that go into that. So you definitely want to check your ingredient labels and things like that if this is something that you're interested in. A lot of these types of supplements have been around and used in traditional and holistic medicine for decades, if not centuries. Those are the positives. Naturally based, centuries of traditional treatment with them, inexpensive, widely available, all great stuff, relatively low risk. So when I say relatively low risk, there are certain side effects that we do need to be aware of. And there are certain side effects and medication interactions that we need to be aware of. So I'm not going to go into those because there's an infinite number of possible combinations. So that's something you want to talk to your doctor and your pharmacist about. But each of those supplements may react with medications in a different way that changes the way your medications work, which may or may not be a problem for you or for your loved one. And so that's why I say relatively low risk. So the downsides of these medications, or these supplements rather, is that none of them have gone through the rigorous studies demanded of prescription drugs. So they haven't been studied the way the things you get from your doctor have been. They haven't been studied even the way that things like Advil and Tylenol have been. So because of that, their efficacy and their safety are unknown. Companies do not have to prove that they can do what they say they're going to do. So when I say this is your as seen on TV miracle cures, you might see a commercial that's like, you need fish oil. It promotes brain health. It improves concentration and focus. It prevents Alzheimer's disease. It improves, memory and learning and all this amazing stuff. They can and will make that up. There's no obligation to prove it. There's no studies done that prove that that's happening. There's also no studies. They can say it's perfectly safe, but there's also no studies that specifically measure the consequences of those. So we're taking them at their word. Connected to that is also that purity and dosage are unknown. Again, we're taking these companies at their word. So they develop their own recipes. They develop their own guidelines for ensuring that those recipes are adhered to. And they determine their own guidelines for what ingredients are used. The FDA is not supervising this process the way they are with, your milk and your bread and your medication prescribed from the doctor. So that means that from one bottle to the next, even if you're using the same brand, you might be getting a completely different actual pill. Even within the same bottle, you might get some pills that have, 50% of the effective ingredient, and some pills that get 5% of the effective ingredient, and everything in between. And we don't know what those fillers are and what those fillers are doing either. So we don't know the purity and the dosage. We can't really prove that. And there's no studies that determine whether or not those dosages are safe and effective. So that's a major downside to these. And so I already touched on this a little bit, but supplements can have significant adverse effects on other medications. They can cause serious side effects, serious drug interactions. They can render essential medications ineffective, which is a problem. And realistically, as we get older, we tend to take more medications. So if you're taking, something for blood pressure that you need, to keep you healthy and alive, and the supplement you're taking is making that medication ineffective, even if it does the miracle things it says it does, which is, kind of hard to prove, is it worth having that improved memory and focus if you have a heart attack because your blood pressure medication isn't working? And so that's why it's so important that we talk to our doctors about adding these. So when it comes to alternative treatments and supplements, as a general rule, if it sounds too good to be true, it probably is. Absolutely still talk with your doctor about whether or not it's worth it. For some people, the relatively low risk of side effects and complications is worth the maybe it does some good, and so that's, again, relatively low harm, but we still want to make sure that we're on top of it. Okay. So then moving on, and this is a very bare bones slide. At the end, I'm going to talk about some things that we want to consider across the board with all of the medication interventions that we've discussed. So this one is just individual symptom management. This is not necessarily for the dementia per se, but it is medications that can help support symptoms that often happen with dementia. Okay, so for example, or just to kind of give a different way of thinking about it, this is like if you got the flu, you might not get a medication specifically for the flu, but you might take cough medicine because the flu makes you cough and the coughing is miserable. So this is the same basic principle. It's not affecting the dementia, but it may or may not help with some of the things caused by the dementia or made worse by the dementia. So those are symptoms like anxiety, depression, agitation, appetite and weight loss. So especially in the later stages, we see a lot of appetite loss for our people with dementia. There are medications that can stimulate appetite to help get them to eat more. Irregular sleep patterns and insomnia. This is a very common one, especially in those moderate and later stages of dementia, where we see people's sleep and wake cycles are very messy and unpredictable. Sometimes they're awake all night and asleep all day. Sometimes they're kind of catnapping 24/7, sleep for 45 minutes, awake for 2 hours, repeatedly kind of a thing. So again, I'm not going to go into specifics about any one of these types of medications because there's probably 15 to 20 minimum options for each of these symptoms, and they're all going to work a different way. They're all going to have different side effects and different interactions, different potentials. So these are things, if you're seeing your loved one struggle with any of these symptoms, you may want to talk with your doctor or your loved one's doctor. about whether or not these medications are a good fit. So then next we're going to talk about treatment and care interventions. These are not medications. These are about the way we deal with and interact with our loved ones with dementia and the ways that we support them to improve the quality rather than the quantity of life. Okay, so these are not going to buy them another 15 years, but they might make the years they have left 50% better. And that's a great thing. So these are very low risk. You know, they're not changing our loved one's physiology at all. This is just focused on their physical well-being, their mental and emotional well-being, their social well-being, and making those parts of their lives as good as possible for as long as possible. So some of these are environmental interventions. This is how we create living spaces that promote safety while allowing autonomy. A lot of times, our seniors, especially the ones with dementia, tend to get treated like children. We view them as very incapable. And that's very frustrating for a great many of them. So if we can make living spaces that give them as much independence as possible, you know, wide walkways, clear walkways, so they're less likely to trip and fall and hurt themselves. Lots of seating areas so that they can take breaks if they're less able to walk long distances or do hard activities. You know, things like, you know, microwaves and toaster ovens as opposed to traditional, you know, gas stoves that can be pretty dangerous. And even those appliances might be a danger to our loved ones at some point. But the idea that we're reducing risks where we can while allowing freedom where we can. Engagement interventions. So these are things that are focused on keeping the mind and the body and the social interaction going. So they promote cognitive health as well as well-being through social and functional interactions. So this is getting your loved one involved in activities, taking them to be with other people like themselves where they can be social, they can have something to do with their time. And ideally, the things that they do with their time are going to mimic real life responsibilities so that they preserve that functioning. So one of the most common for dementia of these engagement type interventions is called the Montessori approach. And it is a process of passive engagement where you basically kind of set up stations, I guess is the best way to put it, where your loved one can choose to interact with things that are important to them and do things that are always available. So that might look like always leaving some, you know, non-perishable snacks or like foods on the table, or even some perishable ones that you're constantly monitoring. So like if your loved one loves apples, you're going to leave out a cutting board and an apple slicer and a basket of apples all the time so that as they're walking through, they can be like, I want an apple, and slice it themselves. You know, if your loved one was a homemaker, a housewife, maybe there's always a basket of laundry sitting around to be folded so that when she's looking for something to do or he's looking for something to do, walks by, sees the basket, stops, folds some. This doesn't have to be necessarily those types of activities. It can also be like leaving out puzzles or crossword puzzle books, word find books. If your loved one is in the more moderate or more advanced stages, maybe they always were a caretaker of children, or maybe they just love children. And you might get some of those lifelike baby dolls and have, you know, a bassinet with a baby in it and they can come along and choose to interact with that baby. Things like that, where it's focused on what they like to do and them initiating those tasks at their own pace. You can certainly do those things with them and use those things to make conversation with them. But a lot of the primary focus of Montessori is about taking advantage of naturally occurring opportunities and letting it be self-directed, so that we do give them a sense of control and autonomy over what they do in their lives. Supplemental therapies. So this is your speech therapy, cognitive therapy, physical therapy, occupational therapy, particularly after our loved one has had an injury or a fall. We definitely want to lean hard into that physical and occupational therapy. But this can also be alternative therapies, art, music, massage, acupuncture, pet therapy, all kinds of things that are really just focused on how do you make somebody feel good? Who doesn't feel better after they've played with a puppy? Who doesn't feel better after listening to their favorite music or getting a good massage or, something to that effect? And can we incorporate those things in a way that helps soothe our loved one's discomfort and give them a better quality of life? Beyond that, we have palliative care. So palliative care is an entire branch of senior care. You can certainly look into some local options and find out more information. But generally speaking, palliative care is focused on how do we improve quality of life through increased comfort and decreased distress. And so the way that it does that is with individual support. So this might be people that come and help with care tasks like hygiene, cooking, things like that. This might be companionship. It often includes pain management. It often includes anxiety management. It can include supplemental therapies, like again, that art therapy, music therapy, pet therapy that we talked about. And it can occur in conjunction with other treatments. Okay. So your loved one can be on palliative care and still get physical therapy. That's a great thing. We manage their pain and we improve their mobility. That's a little bit different than the next one, which is hospice care. So hospice care is one step beyond palliative care. This is also focused on improving comfort, reducing distress, and improving quality of life, but with a specific focus at end of life. So that is to say, we've accepted that our loved one has accepted that they are passing in the not too distant future. We don't want any more treatments. We don't want any more hospitalizations. We just want them to be as comfortable as they can be and as happy as they can be for whatever time they have left. And again, we're doing that with increased individual support to make sure they're clean and comfortable and well cared for, pain management, anxiety and distress management, which might be medication, but might also be counseling or spiritual guidance, supplemental therapies. Typically with hospice care, we're not getting things like physical and occupational therapy, because those are hard and strenuous and demanding on our loved ones at a time when we want them to be able to just kind of float and coast through life and enjoy it. But so when I say supplemental therapies in relation to hospice, it's more that art, music, massage, pet kind of therapies. Individual and family counseling. So one of the things that's really great to know about hospice is that they do provide emotional support to your loved one to help them cope with the fact that they may be dying, but they also provide counseling to you to help you cope with the fact that your loved one may be dying. And so that's a really important distinction, that this also comes with services for you to help make your life a little easier at a really hard time. Hospice care cannot occur with treating and curative therapies. So If you go to the hospital, your hospice care is going to stop while you're at the hospital most of the time. There are, of course, notable exceptions. That doesn't mean you can't reapply for hospice as soon as you're discharged, but typically speaking, it's going to be a new admission to hospice every time. You can't get physical therapy. Often when we put our loved one on hospice care, they're going to stop any medications that aren't necessary for their comfort. So your Namenda, your Aricept that we talked about, we're going to stop making our loved one take those. We're going to stop making them take their fish oil because taking pills is distressing. A lot of our residents take like 5 to 10 pills a day, sometimes multiple times a day. And it's a pain in the tush for them. They don't like it. And so at this point where it's end of life and we're accepting that it's end of life, we're going to stop giving as many of those medications as possible and only focus on the ones that make them feel good, feel better. Pain meds, anxiety meds, antidepressant meds, that sort of thing. So hospice care as a general rule is typically the guideline is 6 months or less to live. That can be scary for a lot of families. We have sometimes the misconception that, well, if I put my loved one on hospice care, that means I'm wishing them death or that they're going to die soon. That is not the case. That is a tentative guideline to give people a way to think about it. It is specifically end of life planning, but I've seen residents stay on hospice for 2-3 years. It just means they get reevaluated every 6 months to determine whether they still need that. And I have seen residents that are going through a really hard time qualify for hospice, and then all those additional supports help them get better and they come off hospice and have years of good life left. So we want to make sure that we keep that in mind and don't let, kind of the feeling of it scare us from something that might be really helpful and necessary for our loved one. And again, this is a conversation you're going to have with their providers. You're going to look at a couple of different hospice providers and see what they offer and if their services are right for you before you make those decisions, and you're making those decisions together. Okay. So for all of this, as I mentioned earlier, there are some things that we want to consider. I especially mean to take these considerations in, keep them in mind for the medications, but this is true across the board for how we deal with our loved ones with dementia, and sometimes for how we deal with ourselves, really. Some of it is just good advice. So regardless of what treatment options you're thinking about, regardless of what treatment options you're talking with your doctor or your loved one's doctor about, we want to keep in mind these handful of things. So the first is the difference between consent and assent. So often for our loved ones with dementia, we're their powers of attorney. We have the ability to make a lot of their decisions for them. And that's a good thing because decision-making is very challenging for people with dementia. It can be very stressful. They often don't understand the depth of the decisions that they're making. But whenever possible, we want assent to, which means they might not have the power to legally make the decision, but they should still be okay with it. We want our loved one's voice and wishes to be reflected in all of the decisions that we make. We want to make sure that we're making decisions that are in their best interests, not in just our own. So, especially in those early stages, they can be part of that conversation. You can explain to them what you're thinking about, have them be part of the doctor's appointments, and find out how they feel about taking another medication or about changing a medication, or about trying something new, because they might have very strong feelings about it. In their later stages, we're going to make the best guess we can based on who we knew them to be. So especially at the end of dementia, where our loved ones really can't understand what we're talking to them about and maybe can't verbalize what they would want to do, We're going to make the best guess based on a time when they could make those decisions. What would they have wanted? What do we know based on, or, like, what can we guess based on what we know? Okay. We always want to consider when we're doing this, who is this a problem for? And what other options are available? And so when I say, who is this a problem for? Realistically speaking, let's just call a spade a spade. Sometimes we want to medicate things because it makes our lives easier. If our loved one is very argumentative and kind of nasty sometimes, we might be tempted to give them something that's going to chill them out. But if they are happy and capable and living their lives, and we want to drug them to make our lives better, we might want to rethink that. So it's just, and we want to consider too, is there another way we can do that? If they're argumentative, if they're fussy, if they're, difficult at times, is there something else that can do that? Can we change our approach? Can we get them more social interaction? Can we help them feel better about the things that make them irritable? Are there proactive approaches we can take to help reduce that conflict? So and this is like something minor, but even if, let's say you're consistently showing up to visit them after work at 5 p.m. and you're fighting with them constantly because that's a time of day when they're getting tired and they're worn out and they've already had a full day. And for a lot of people, that's when sundowning or an increase in symptoms begins. That's really on you, and I get your job is important, but maybe you come on days off, or maybe, you work late one day so you can leave a little early another day so that you can be there at a time of day that's more conducive to them, rather than medicating them so that your schedule is more flexible, that kind of thing. So we want to really consider, who is this actually a problem for? And are we doing the right thing? And are there other things we could be doing instead? We also want to take into consideration quality of life from a physical versus mental versus emotional kind of concerns, and making sure we're weighing all of those when we make a decision. So this is especially with things like those supplements, if we're thinking like, oh, they can take a fish oil, what's the harm? Maybe it helps, it doesn't really hurt, everybody wins. Well, again, taking more pills is distressing for some of our residents. So yeah, the medication itself, the supplement itself might not have a bad consequence. But if having to take it is going to stress them out, is that maybe benefit worth that definite, consequence? And those are things that we need to think about. We also want to keep in mind that sometimes things that seem low risk can have other consequences. Fish oil can cause a lot of problems with acid reflux and GERD. If your loved one has GERD already, there's physical and emotional consequences to taking what we consider to be a harmless medication. So we want to make sure we're looking at all of those pieces before we make our decision. We want to consider too that everyone's tolerance is different. So your loved one might be fine, taking that, but somebody else's might not be. I've got residents that take 15 pills at a time like it's nothing. And I've got residents that'll look at the one Tylenol they asked for in your hand and say, what is that? And I'm not taking it because I don't trust you. And it's like really dependent on the person. Different physical tolerances for medication. Some people can handle taking, a lot of pills. Some people are going to get an upset stomach if they do. And so we have to know our loved one and what their tolerance is and take that into consideration as well when we make those decisions. We also want to consider medications can have adverse or even opposite effects for individuals with dementia. So this is especially true. So that slide where I said I'm just going to kind of be general for the symptom management, the anxiety, the depression, the insomnia, that sort of thing. Sometimes those medications do the opposite for people with dementia. So you might say like, well, I take a Xanax now and then when I'm stressed, why can't they? And Xanax for them might make it better temporarily, but might increase their risk of falls. What's better, a little anxiety or a broken hip? That's not my call to make. It may even make the anxiety worse. Sometimes we give residents with dementia anxiety or Xanax and find out that it causes aggression that we didn't see before. Again, to come back to that idea of how the brain works and neurotransmitters and those chemicals in the brain, it's kind of like like water in a kiddie pool, So when our synapses are close together, when our nerve cells are close together and those gaps are small, it takes a little bit of water to fill it. It takes a little bit of that chemical to fill it and to fix it. And so those medications that work on neurotransmitters, on those chemicals, like our anxiety meds, our depression meds, our sleep meds, it's okay. But as the brain cells die and drift apart and those gaps get bigger and bigger, you can pour an Olympic pool amount of medication into that gap, an ocean of medication into that gap, and still not get the desired effect, because the communication just isn't there between brain cells. And so we might see that these medications do nothing. We might see that we get all the side effects and none of the positive effects. And that's something we have to be careful of. And some of these medications even have what we call black box warnings, where they are completely not recommended for people with dementia. That is to say, there are times when medications not intended for use with dementia work for people, because again, everyone is different. So there's an outside case for everything. If your loved one has been on Abilify for the last 20 years and gets diagnosed with dementia and that medication has done them well, it's probably fine. But if your loved one's prescriber is considering Abilify now, it's not recommended for people with dementia. And it can have pretty disastrous consequences if you get that black box warning. Particularly some types of dementia, like Lewy body dementia, can have really counterproductive effects with psych meds, especially. And some of those potential side effects are deadly. So definitely something we want to take into consideration. The way that medications affect a healthy brain and the way that medications affect the brain with dementia can be and often are very, very different. So we need to know that. If we decide, even with all of those risks and things in mind, that the medication is so worth it. And I know that this kind of all probably sounds very scary, and it sounds like, I shouldn't do any medication. But that's not necessarily true. There are people that medications work wonders for. We just want to be careful about it. So we have to make sure that the benefits outweigh the risks. If we decide that the benefits of medication outweigh the risks, then we still need to make sure that the medications are being prescribed under a watchful and trained eye. We need to make sure that they're being prescribed low and slow. So that's to say, low dosages that we try out for a good amount of time before we increase the dosage. That can be very frustrating. We need to allow time to see how they affect our loved one. So especially for those psychiatric medications, our anxiety, depression, insomnia meds, they can take 2 to 3 weeks before we really start to see results from them, because our brain has what's called the blood-brain barrier to protect it from letting toxins in. If we just let everything that we encountered get into our brain, we'd probably be a lot more messed up, but our blood-brain barrier protects us. The downside of that is that when we take these medications, we don't tend to see immediate effects. It can take 2 to 3 weeks, sometimes 4 for some individuals, before we really see whether or not a medication works. And so we're starting at a really low dose, and then we've got to wait 3 weeks to see if it works. And then if it doesn't, is that because the dose is too low? Or is that because it's not the right med? And how do we know? And again, that's the doctor's decision. That's why we're using that medically trained watchful eye. And if the consequences don't seem too bad, maybe it's just a dosing problem and we gradually increase until we get to a place where it works. If we're seeing negative side effects at that point, that's a good sign that's not the medication for our loved one. And then we have to give 2 weeks to come off of it before we can reintroduce another medication. So that process of trial and error can be very frustrating, but it's essential for the safety of our loved ones. And it's important to know that with dementia, sometimes side effects can be long lasting or even permanent, even after a medication is decreased or reduced, or discontinued. So we might try them on a medication, and it is rare that this happens, but I have seen it happen where we try them on a medication that we genuinely think is going to be the best course of action for our loved one. And we see things get worse and not better. We take them off the medication, hoping the problem goes away, and sometimes decline is permanent. And it's very sad and it's very heartbreaking, and it can be very easy to feel guilty for having put our loved one through that if we have that experience. We have to know that we were trying to do right by them. And so that's why all these other considerations, making sure that their voice is involved in the process, making sure we're focused on doing this for the right reasons, making sure that we're balancing their physical needs, their mental needs, their emotional needs, making sure that they're being prescribed correctly and by knowledgeable physicians. That's why those steps are so important, so that if the worst happens, we still know we tried. We still know we did what was right, even if it went wrong. The sad reality of life is sometimes you can do everything right and things still go sideways. And so it's a small risk, but it's a risk we need to be mindful of. And all of this, it's also worth noting that it's sometimes easier not to make a change than it is to reverse a change we've made that didn't work out the way we expected. If our loved one has been on Namenda for the last 6 years, and now they're not doing so well with it, and we think it might be making their anxiety worse, we have to decrease that gradually. And that's more time they're in distress. That's more time they're anxious. That's more time, and that's just one example. It's not to say that that medication specifically is responsible, but changes sometimes can be hard to undo. Like if you squeeze all the toothpaste out of the tube, you can't very easily put it back in, kind of a situation. So we need to make sure that we're thinking through all of the possibilities before we make a change, because sometimes they're hard to change back. Okay, so hopefully I answered all your questions. But if I didn't in the interim while I am still out on leave, you can direct all of your questions to Pam Garofolo. She is our corporate director of Tapestries. She's my supervisor. She oversees all of our memory support communities. She is a wealth of knowledge and experience, both in her personal life with her own mother and in her professional life with us and her entire professional history. So she knows a lot, and she is available to answer your questions or address any concerns that you might have. So you can see her contact information here on the screen. Please, by all means, feel free to reach out to her if you have any questions I didn't address, or if you have more specific information you're looking for, or just, need somebody to bounce something off of, she's a really great resource and a lovely, wonderful person. So I'm sure she'll be happy to help you. Next month, we're going to continue to talk about medical decision making, but not specific to dementia. Well, specific to dementia because that's our focus, but when a medical need is not dementia related, but impacts our loved one with dementia. So we're going to go through a lot of other things. Hopefully you'll be able to join us for that. Thank you so much. I hope you have a lovely day.